Good afternoon, everyone. Yeah. So the topic is out of one into another. So this is a case presentation. This is a case where we are also having a lot of diagnostic dilemma. So it's an open-ended case where people can pitch in. So there is a 35-year-old male, and his complaints was floaters in the right eye for a week, and blurred vision in the right eye for a week. And there was a history of typhoid fever 3 weeks back, and the patient had a history of CSR much before this a year ago, and for which he was under treatment at that time, topical and oral medications, no laser or anything. And now coming to the presentation, you can see that there is a retinitis patch along the infratemporal arcade with hemorrhage and edema, and there was a ERM at the macula, and there was some RP degeneration. This was the OCT going through the lesion, which is showing a diffuse. Uh, there was actually no total loss of anatomy, which is destructive anatomy at that area. And the other eye you can see has also CSR, like a fluid parafoveal and coming subfoveally with a small PED. And this was the FFA of the patient, and you can see that there is no a typical early hypo, late hyper in a case of a classic retinitis. There is just a diffuse staining of that in the very late phase. And in the other eye also there are multiple window defects which is suggestive of sick RP, but there is no focal leak or there is no this thing which is suggestive of fresh CSR. So there are two options now. There is either and in the OCT also there we couldn't find any cells in the vitreous cavity or anything like that. So there could be, it could be either post fever retinitis or a central CSR. But the treatment are totally different for both. For a post fever retinitis, we would start the patient ideally on steroids, and for CSR, ideally we should avoid giving steroids. So there was a management dilemma, but because the patient was having a history of typhoid, so we went along with the diagnosis of post fever retinitis. This was the day macular OCT on the day of presentation. You can see a parafoveal SRF packet. We started the patient on cotrimoxazole and omnocartil 60 milligram and a weekly tapering dose. And you can see 2 weeks post steroid, there was an increase in the SRF at the macula, and there was a huge SRF in the left eye also. So this is now becoming into a CSR which is decompensating because of oral steroids. So then now we thought, okay, let us quickly taper the steroids and continue on the oral antibiotics. And there was also the second thing was we started the patient on eplerenone. We did not do any hormone serum cortisol levels, but we just started the patient on tablet eplerenone. And post 4 weeks of eplerenone, you can see now that the SRF in both the eyes have started resolving. And the retinitis patch also, you can see that there is a reduction in the hemorrhage and surface vascular hemorrhage and the SRF, and there was a surface vascularization around 6 weeks after the initial presentation. Till now, at any point of time, there was no vitritis or anything like that for the patient. So this is post 8 weeks, and you can see that almost all the SRF has resolved after continuous eplerenone to 50 milligram dosage. And the inferior retinitis patch has also become almost near inactive. But although in a typical retinitis, there will be pigmentation as the lesion starts healing, which is not there in this case. There is just a white patch which is still there with some amount of surface vascularization. So the questions we have are, how could we have managed this differently? Should we have just started Septran TM without the oral steroids? Could we have managed the CSR differently? Because we did again an FFA, but there was no leak, so we couldn't do any focal laser. Was eplerenone that acted in our case, or was that the natural course of steroid reduction which reduces CSR? Was it even a retinitis in the first place, because there was no vitritis, and although there is a surface hemorrhage and it reduced, we still are not sure whether it was retinitis, because it's such a localized patch in only one eye. And now that CSR is resolved, how frequently should we follow up this patient? These are some of the questions we are posing, and that's it. Thank you.
So it is a problematic case presented, which needs to be answered by the.
Just go back the slides
to
the point where you added
eplerenone.
Yeah,
There you
and
have
the slide
steroids.
before that.
You have steroids as well as eplerenone. Just go back.
Yes.
So I was wondering why.
So this was the okay, this is the time I started on.
This is where you started.
The post 2 weeks, the patient presented in the second one. This is how he decompensated, and at this point I started eplerenone.
Go one slide back.
This was the presentation.
And then go to the next slide.
This is the same slide I have put in the same thing up and down.
So is the hemorrhage reducing there?
Yes, sir, the hemorrhage is
And
reducing.
is the
there.
retinitis
Yes,
patch getting
yeah,
localized?
it
This
is
is before you added.
added
the-
eplerenone. Yes,
Yeah.
sir. Yes, sir. Yes, sir.
And just the next slide to this.
Yeah. And this is 4 weeks later. The hemorrhages have almost totally regressed. There is, but there was some small fibrillary surface vasculature which was there. I can zoom in. Yeah, you can see there is a minimal surface vascularization at that point, which was not there previously. And I don't know whether it's a classic CSR or not, but I mean classic retinitis or not, but it is a weird case because there was no vitritis also at any point of time.
So it could be a self-healing also, according
Yeah,
to me.
yeah, could be.
All right.
Okay.
Any comments
Yes,
from
ma'am.
Dr. Manisha?
So I have two, three things.
Yes, ma'am.
One is that you are dealing with a patient who has a history of chronic
Yeah.
CSR. The patch was very much away from the macular area, so there was really no hurry for us to add steroids.
Steroids.
We could have just observed this patient and allowed that patch to heal.
Right.
Second is, I would have loved to see a posterior vascular cleft.
There is a first slide as it.
No, but that's through the macula, na? Not
Through,
through
no,
the
no, no.
patch.
First, through the macula at the first
No,
visit.
no, no.
The lesion is there, ma'am. I mean, can you
It's
just
a
put it
little
up?
far away. I think you couldn't take the.
No, no.
visit-
I have taken only the first visit we could take. After that, we did not take it. This was the one, ma'am.
Where is that vascular?
Through the lesion, ma'am. This is through the lesion, is what it is. Excuse me. एक और बार लगा. This one, ma'am. This is through the lesion.
This is through the lesion. So it is surely a patch of retinitis.
Yes,
You
ma'am.
are seeing a PED also.
Yes, ma'am. There is a PED also.
So, and the other thing is that since you added the steroids, you had a
Decompensation.
SRF coming back.
Yes, ma'am.
You know it's a steroid response.
Yes, ma'am.
So there was again no hurry to add eplerenone.
Okay.
Because if you would have stopped the steroid, the SRF itself would have risen.
Right. Right.
And because this patient has a history of typhoid fever, this retinitis patch can always, develop as a post-fever recovery.
Right.
So I personally would have just observed, and there's absolutely no vision-threatening lesion.
Right. Right.
So I personally would have just observed.
Okay, ma'am. Point taken.
So to say these are, these are two separate entities.
Yeah.
I mean, you had a post-fever retinitis,
Yes, ma'am.
which you treated.
Yeah.
You caused a side effect.
effect,
Then you
we
treated the
treat
side
that
effect,
also.
which you could have just observed.
So good. It's a nice case.
Thank you. Thank you.
It's rather a learning case. Huh?
Yes. So sometimes observation is